Chrysin is a polyphenol and it's found in a variety of plants, and it's particularly concentrated in bee products like honey and propolis. Like many other flavonoids, chrysin has free radical scavenging, anti-inflammatory, antiviral and anti-cancer activities. Although few human studies have been conducted with chrysin, animal studies and in vitro suggest that it can protect against DNA damage, and it modulates several cell signaling pathways that are involved in cancer progression, including those affecting inflammation, cell survival, cell growth, new blood vessel growth, and metastases. Chrysin, like other polyphenols, is poorly absorbed in the digestive tract. However, new techniques are being developed to improve its availability and uptake in the cells, to sustain higher levels in the blood over long periods of time, and to enhance its anti-tumor activities. Chrysin has been shown in human cell cultures to inhibit aromatase, an enzyme that converts testosterone into estrogen in both men and women. Aromatase inhibitors are important for the treatment of tumors as they're stimulated by estrogen, such as many of the breast cancers. If chrysin, or a molecule derived from chrysin, is found to inhibit the aromatase in humans, it might be especially helpful as an adjuvant therapy in people with estrogen-sensitive cancers. CoQ10 is a biomolecule with a high capacity to reduce free radicals. It's found in the cell membranes throughout the body, and it plays an integral role in cellular mitochondrial energy production through the oxidative phosphorylation pathway. CoQ10 is produced via the same chemical pathway that results in cholesterol production. Statin drugs, which are used primarily to lower cholesterol levels, inhibit an enzyme on the cholesterol synthesis pathway. While this action of the statin may also suppress cancer progression, it poses an unintended consequence of interfering with the CoQ10 production. Supplementing with CoQ10 has been shown to restore the CoQ10 level in statin users and mitigate some of the negative consequences of statin therapy. In addition, CoQ10 may have independent anti-cancer benefits. Interestingly, even in the absence of statin therapy, people with cancer are more likely to have a CoQ10 deficiency than healthy individuals. Dr. Carl Volkers, a pioneer in the study of CoQ10, was perhaps the first to demonstrate the relationship between low CoQ10 levels and cancer. A subsequent study noted a correlation between the degree of CoQ10 deficiency and breast cancer prognosis. Dr. Volkers also showed that CoQ10 can improve a marker of anti-cancer immune function, and reported several case examples where cancer progression was halted after treatment with CoQ10. A more recent study included 41 patients with various end-stage cancers who received CoQ10 along with a combination of antioxidant supplements. 76% of the subjects lived longer than predicted, while the other 24% did not. One of the mechanisms behind the apparent anti-cancer effects of CoQ10 might be its anti-inflammatory activity. In one trial, 41 patients undergoing surgery for liver cancer took either 300 milligrams of CoQ10 or placebo daily for 12 weeks. Blood levels of markers of oxidative stress and inflammation were significantly decreased in the patients taking the CoQ10. CoQ10 may be of particular benefit for women who are taking anti-estrogen drug tamoxifen. In one clinical trial, a combination of CoQ10 at 100 mg per day, riboflavin at 10 mg per day, and niacin at 50 mg per day was added to tamoxifen therapy in women with breast cancer. Tamoxifen alone, taken for 1 year or longer, reduced the levels of 2 tumor markers, as well as markers of inflammation and new blood vessel growth. The addition of the CoQ10 combination resulted in a further decrease in these levels after 45 days and again after 90 days, suggesting that the supplement may have enhanced the effects of tamoxifen. The supplement also appeared to trigger DNA protective and epigenetic changes, indicating less cancer in the body and a better prognosis. CoQ10 may be helpful for patients who are treated with chemotherapy agents that are toxic to the heart, most notably doxorubicin. heart muscle damage can develop slowly and can manifest 15 years or more after the treatment. CoQ10 has been shown to protect against the heart muscle damage in animals who are exposed to the doxorubicin. Other research suggests CoQ10 does not interfere with the anti-cancer effects of doxorubicin. In fact, CoQ10 may increase the tolerance to doxorubicin, allowing for longer or higher dose treatment, enhancing the efficacy. Given the value of CoQ10 in improving heart function and cardiovascular health in general, it may be beneficial as a co-treatment during chemotherapy with doxorubicin, and it's an essential consideration for supporting heart health for years or even decades after treatment with a heart-toxic chemotherapeutic agent. Coffee contains many phytochemicals that have been demonstrated to have anti-cancer properties. Preclinical studies have shown certain coffee constituents can promote cancer cell death, reduce the ability of cancer cells to invade and spread, reduce new blood vessel growth, which is required for tumours to grow, and improve the anti-cancer immune activity. Although the data is inconsistent, some studies have found that coffee drinkers are protected against certain cancers. The strongest evidence for the cancer preventative effects of coffee was found in regard to liver and endometrial cancer. Coffee may also protect against the most aggressive prostate cancers. In one study that included 47,911 men drinking 6 cups or more of caffeinated or decaffeinated coffee per day, was correlated with a 60% lower risk of lethal prostate cancer compared with drinking no coffee. Coffee consumption has been associated with better colorectal cancer outcomes in 2 separate studies. The first study followed 953 people with invasive stage 3 colorectal cancer. Participants who consumed 4 or more cups of coffee per day had a 42% lower risk of recurrence or death than the non-coffee drinkers. A smaller benefit was seen in participants drinking 2 to 3 cups per day. Participants drinking 1 cup or less did not derive any colorectal cancer outcome benefits. The second study involved 1,599 participants who were diagnosed with invasive stage 1 to 3 colorectal cancer. Over the course of 7.8 years of follow-up, participants who consumed at least 4 cups of coffee per day had a 52% lower risk of death due to colorectal cancer than the participants who didn't drink any coffee. In addition, the participants whose intake before and after the diagnosis was consistently more than 2 cups per day had a 37% reduced risk of cancer-related death and a 29% reduced risk of death from all cause than the patients who consistently drank less than 2 cups per day. Coffee may also affect the outcome in some women with breast cancer. One study included 1,090 women who were treated surgically for breast cancer. Among a subgroup of participants with estrogen-sensitive cancer receiving tamoxifen, they were followed for 3 to 9 years after surgery, and daily coffee intake of 2 or more cups per day was associated with a lower risk for breast cancer recurrence. A separate study also found coffee consumption appeared to lessen the number of recurrences during 3 to 6 years of monitoring in the women taking the tamoxifen after the breast cancer surgery. Women carrying the breast cancer susceptibility gene, BRCA mutation, which are linked to breast cancer risk, may derive particular benefit from coffee. A research analysis that included data from 40 clinics in 4 countries and involved 1,690 carriers of the BRCA1-2 mutation found that coffee intake was correlated with lower breast cancer risk, and the protective effect rose with the increasing level of coffee consumption. Compared with women who didn't drink coffee, the likelihood of being diagnosed with breast cancer was 10%, 25% and 69% lower in the participants who habitually drank 1 to 3, 4 to 5 or 6 or more cups of coffee respectively. Conjugated linoleic acid, or CLA, is a group of fatty acids derived from the essential omega-6 fatty acid linoleic acid. CLA has been shown in several studies to have anti-cancer properties. These include decreasing cell proliferation, causing cell death, suppressing metabolic pathways, and inhibiting metastases. In a preliminary clinical trial, women with breast cancer were given 7.5 grams of CLA per day for at least 10 days before surgery. When tumour tissue from the surgery was compared with tissue from the original tumour biopsy, markers of cancer cell proliferation were reduced. In addition, the CLA appeared to alter the regulation of the fatty acid synthesis, which may have been a contributing factor in its anti-proliferative effect. Although research suggests CLA may reduce the proliferation of estrogen-sensitive breast and endometrial cancer by affecting estrogen receptors, in a randomized placebo-controlled trial, 34 patients with rectal cancer received either 3 grams of CLA per day or placebo, beginning 1 week before a 6-week regime of chemotherapy plus radiation therapy. The patients who were taking the CLA had lower levels of inflammatory markers and enzymes involved in tumour progression and metastases, and these findings suggest the CLA may be useful as an adjuvant therapy for rectal cancer. Through its action on fatty acid metabolism, the CLA has been shown to increase fat burning and to decrease fat deposition in the body. Healthy body composition with greater weight from muscle and bone and less from fat is ideal for limiting systemic inflammation. CLA has been found to improve liver function in patients with non-alcoholic fatty liver disease, a metabolic disorder where the fat accumulates in the liver. Many cancer survivors have an increased risk of fatty liver, including those who have received high doses of steroids, those on tamoxifen, and those with elevated fasting glucose. EPA and DHA are the major omega-3 fatty acids found in fish oil. The EPA and DHA are incorporated into the cell membranes, where they help to maintain fluidity, support normal cell membrane activity. They're a source of anti-inflammatory compounds, and they disrupt membrane structures called lipid rafts. Lipid rafts are discrete regions composed mainly of cholesterol and saturated fatty acids, and these form in a cell membrane and affect the membrane function. Lipid rafts are thought to play a role in cancer promotion by influencing cell survival, immune cell activation, and the movement of protein and lipids across the cell membrane. Lipid rafts can also harbour proteins that promote cancer growth, known as oncoproteins. DHA has been noted to displace several lipid raft-associated oncoproteins in the lab. Inflammation is a central mechanism for cancer progression, and omega-3 fatty acids from fish reduce inflammation in multiple ways, including suppressing NF-kappa B, regulating inflammatory enzyme activity, and acting as precursors to molecules that deactivate the inflammatory process. DHA has also been found to inhibit enzymes that are needed for glycolysis, reducing the ability of cancer cells to make energy from glucose. In addition, omega-3 fatty acids may act epigenetically to alter the cancer risk. Higher intake of omega-3 fatty acids from fish has been associated with lower risk of colon, prostate, and breast cancer in some, but not all, studies. Inconsistent findings may be related to genetic differences in the ability to metabolize these fatty acids, differences in baseline intake levels and supplement doses, and differences in omega-3 to omega-6 fatty acid ratios. EPA, DHA, and fish oil have been found to increase cancer cell sensitivity, resistance to, and to improve effectiveness of various chemotherapeutic agents in animals and lab models of brain, colorectal, breast, lung, and bladder cancer, as well as leukemia and lymphoma. EPA and DHA have been shown to induce DNA damage in cancer cells but not in normal cells, potentially making cancers more sensitive to chemotherapy and radiation, without increasing the toxicity to normal tissues. The daily use of oral omega-3 fatty acids for supportive care in patients with cancer continues to hold promise. A controlled clinical trial with 46 participants found adding 2.5 grams per day of a combined EPA-DHA to standard chemotherapy for advanced non-small cell lung cancer led to better outcomes than chemotherapy alone. The participants receiving EPA and the DHA had a higher response rate with greater clinical benefit, and they appeared to have better 1-year survival rates. In another study, 30 patients with colorectal cancer received 2 grams of fish oil, providing 600 milligrams per day of combined EPA and DHA for 9 weeks during standard chemotherapy or chemotherapy alone. The participants taking the fish oil had a significantly longer time until the progression of their disease. A research review noted the clinical evidence that the fish oil fatty acids improve the immune ability to prevent the loss of muscle mass and to increase the quality of life and the overall survival in the patients with colorectal cancer and pancreatic cancer. Omega-3 fatty acids may reduce the negative side effects and the toxicities related to cancer treatment. One study found a connection between a higher intake of omega-3 fatty acids and lower levels of post-treatment fatigue in breast cancer survivors. In a trial including 61 patients with esophageal cancer, taking an enriched nutritional formula providing 900 milligrams per day of omega-3 fatty acids for 15 days during the chemotherapy, it was associated with fewer mouth ulcers, lower levels of markers of liver damage compared with a nutritional formula providing only 250 milligrams of omega-3. Several studies have shown omega-3 fatty acids can prevent or reverse cachexia, a wasting syndrome that's commonly seen in patients with advanced cancers, and it's associated with poor outcomes. In patients with advanced colorectal cancer, taking an EPA-enriched nutritional supplement, providing 1 gram of EPA per day for 12 weeks during chemotherapy, resulted in weight gain and appeared to improve the quality of life scores more than the chemotherapy alone. In a control trial including 111 patients with head and neck cancer, participants who also received nutritional supplement enriched with EPA and DHA during standard treatment with chemotherapy and radiation reported a better quality of life and experienced less weight loss after 14 weeks of treatment than patients receiving an unenriched nutritional supplement. Omega-3 fatty acids may support positive outcomes after cancer surgeries. A review of the research found that nutritional formulas enriched with omega-3 fatty acids reduced post-surgical complications and infections and shortened hospital stay in patients undergoing liver surgery for both benign and malignant conditions. Anti-cancer effects of omega-3 fatty acids may also improve the status of patients with cancer before surgery. In a randomized control trial, patients with colorectal cancer awaiting surgery to remove liver metastases were given either 2 grams of EPA per day or placebo for 12 to 65 days before surgery. Although no difference was noted in the proliferation of the cancer cells between the groups, the patients who were taking the EPA had fewer blood vessels in their tumours. Enzymatically modified rice bran, which contains an immune-modulating polysaccharide called arabinoxylan, has demonstrated anti-cancer potential and it might enhance chemotherapy's effectiveness. Some evidence also suggests the formulation may reduce some of the negative side effects of radiation and chemotherapy. A number of studies have found modified rice bran can activate the anti-cancer immune response and inhibit tumour formation and growth in animals. In particular, enzymatically modified rice bran can stimulate natural killer cells and dendritic cells, 2 types of immune cells that are critical for the body's response to cancer. In a 3-month randomized control trial with 48 participants who had multiple myeloma, treatment with enzymatically modified rice bran increased the natural killer cell activity, the blood levels of dendritic cells, and the level of some beneficial immune molecules. Lab research indicates the enzymatically modified rice bran can also inhibit the formation of new blood vessels, which would limit the tumour growth. Preclinical and clinical studies suggest the enzymatically modified rice bran might be useful in combination with standard cancer treatment. In a randomized control trial, 68 patients with liver cancer were treated with conventional therapies, either alone or with the addition of 1 gram per day of rice bran arabinoxylan for 12 months. After 3 years, the patients who'd received the rice bran had a greater decrease in tumour size, lower tumour markers, and lower recurrence rates. In addition, the 2-year survival was 35% in patients taking rice bran versus 6.7% in patients who were receiving the conventional therapy alone. In lab research, enzymatically modified rice bran increased susceptibility of breast cancer cells to chemotherapy drugs. In an animal model of cancer, modified rice bran demonstrated stronger anti-tumour activity than a low-dose chemotherapy, and the combination of the modified rice bran plus the low-dose chemotherapy was more effective than either alone. Enzymatically modified rice bran worked synergistically with curcumin to promote cancer cell death in lab research, and the combination helped to improve immune cell numbers in a preliminary clinical trial where patients had early-stage blood cancer. The first paper to describe the anti-cancer activity of garlic's constituents was published in 1958. Other lab and animal research has shown that garlic also acts indirectly by reducing inflammation and by stimulating anti-cancer immune function to inhibit tumour growth. In addition, garlic appears to alter epigenetic regulation of the immune function, cell death, and toxin metabolism in ways that may reduce cancer development and progression. Consumption of garlic and related vegetables might be associated with low risk of certain cancers. The best evidence of a protective effect is for esophageal, stomach, and colorectal cancer. Garlic contains nutrients that could contribute to its possible benefits, including magnesium, selenium, amino acids, vitamin B, A, and C. In addition, garlic is a rich source of sulfur compounds with anti-cancer effects. These active sulfur compounds are formed through enzymatic activity when garlic is cut or crushed. Aged garlic extract may be helpful for individuals who are prone to precancerous colorectal polyps, known as adenomas. In a randomized trial, the participants with a history of colorectal adenomas treated with 2.4 milliliters daily of aged garlic extract had fewer and smaller new adenomas after 12 months than participants who were treated with a 0.16 ml daily. In a small clinical study that enrolled 50 participants with inoperable colorectal, liver, or pancreatic cancer, supplementation with aged garlic extract increased the natural killer cell numbers and the activity compared to a placebo. Natural killer cells play an important and complex role in the immune's response to cancer. Inositol hexaphosphate, or IP6, is also known as phytic acid or phytate, and it's a naturally occurring fiber component and storage form of phosphorus. IP6 is found in almost all plants, and it's abundant in plant foods like whole grains, vegetables, and legumes. Although IP6 has long been considered an anti-nutrient because of its propensity to bind to minerals and proteins, it's now also recognized for its important health benefits and its anti-cancer potential. High-fiber foods are a rich source of IP6, and they've been associated with lower risk of cancer, especially colorectal cancer, in numerous studies. IP6 is active against many types of cancer cells in the lab. Preclinical studies suggest IP6 might enhance the body's ability to defend itself against cancer through several mechanisms, including lowering oxidative stress levels, activating the natural killer cells, altering cancer cell function and signaling, inhibiting tumor growth and metastases, and stimulating normal cell division and cell death. Additionally, studies show IP6 increases levels of tumor suppressor gene p53 and inhibits inflammatory signaling via NF-kappa B. IP6 may be particularly helpful in conjunction with other cancer therapies. IP6 plus inositol was compared with a placebo in a trial with 14 women receiving chemotherapy for breast cancer. The patients who were receiving the IP6 had less bone marrow toxicity, reflected by higher numbers of blood cells, including platelets and white blood cells. In addition, the overall quality of life was preserved to a significantly greater extent in the IP6 treated women. Early reports of the benefits of IP6 as part of adjuvant therapy after cancer surgery were presented at the 7th International Conference of Anti-Cancer Research in 2004. IP6 plus inositol at a dose of 1,530 mg 4 times daily during chemotherapy and twice daily for 1 year after treatment was noted to prevent the treatment-related side effects and to preserve the quality of life in the patients with colorectal cancer. Similarly, in patients with breast cancer, 2,040 mg of IP6 plus inositol 3 times daily during chemotherapy and radiation, and 510 mg 3 times daily after the end of treatment reduced side effects and prevented a decline in quality of life. In these small studies, the IP6 was taken 30 minutes before meals to minimize its anti-nutrient effects. For more information about herbs, supplements, and natural treatment plans, check out my website.